Well, good morning, and I will start the Grand Rounds. So for today's Grand Rounds introduction, I thought I'd say 7 great things about our speaker, Dr. Francesca McCaffrey. Number 1, Dr. Francesca McCaffrey is a successful third-year resident here at Sanford Children's Hospital. Number 2, Dr. McCaffrey was born in Albany, New York, and was raised in Warrensburg, New York, a town of 4,000 that takes pride in its title of Gateway to the Adirondacks. Number 3, in August 2006, Francesca taught English to high school students in Lantian, China. Number 4, Francesca achieved her Bachelor of Science degree in biology with a minor in chemistry at Clarkson University in Potsdam, New York in 2009. Number 5, from 2010 to 2015, Francesca developed a breastfeeding toolkit and support protocol for the early child care and education centers in the Mid-Coast Maine Public Health District. She achieved a Master of Public Health at the University of New England College of Graduate and Professional Studies in Portland, Maine, and she graduated from the University of New England College of Osteopathic Medicine in Bidford, Maine. From 2015 on, Francesca joined the Professional Writing Resource Faculty at the University of New England Graduate Public Health Program, a role she continues to fulfill today. Number 6, in July 2015, Dr. McCaffrey enrolled in our residency program. While here, she co-authored 2 poster presentations, one at the 2016 Pediatric Hospice Medicine Conference in Chicago, entitled A Homeless 17-Year-Old with Agitation, Positive Drug Screen, and Cough, When Crazy Isn't Crazy, and one at the 2017 Pediatric Academic Society's National Meeting in San Francisco, entitled Quality Improvement and Parent Satisfaction with the Transition to Transcutaneous Bilirubin Meters in the Newborn Nursery. Dr. McCaffrey is also a clinical instructor in our Department of Pediatrics at the University of South Dakota Sanford School of Medicine, where she helped set up a simulation boot camp for the Medical Student Pediatric Interest Group. She also served on the GME Committee, the Sanford Children's Hospital Neonatal Care Services Committee, and the Residency Wellness Committee, and has had a brief turn as interim chief resident. Dr. McCaffrey's passionate advocacy for breastfeeding has improved resources for both residents and parents at Sanford. Number 7, in her residency application, Francesca wrote, "The effortless excitement of working with children and affecting real change in the lives of future generations is most certainly a reward for finding my calling." We are glad Dr. McCaffrey's calling is pediatrics, for she has certainly achieved change for the better in our residency program, our department, and our hospital. So please welcome Dr. McCaffrey as she talks about 7 great advancements.
Thank you.
Come on up.
So I'm going to start by saying that I'm going to try not to stand behind the podium because I had a night shift last night and I'd like to keep my blood flowing. And so if I get too antsy or moving around a bit, Kyle, I expect you to give me a wink from the back aisle there to let me know. And I really appreciate that Dr. Zennel started with the comment about that line in my personal statement, because as I'm hearing it, it's really going to resonate with the final point that I'd like to make today with this Grand Rounds topic. And I'd also like to say that we don't actually know what Dr. Zennel is going to say when he introduces us, and I don't think many of us remember what we put in our personal statements, and so it is a little bit nerve-wracking knowing that that was how this was going to start, but it was perfect, so thank you for that. So this Grand Rounds experience for all of us residents is something that is required for us at the end of our residency. And, you know, over the course of our 3 years here, as we're trying to find a topic, we're involved in a lot of things, a lot of projects. You know, perhaps the thing that I do for my Grand Rounds would be associated with some of the research I did or some of the quality improvement. And so in the past several months, I found myself kind of mulling over this topic of what I was going to present to people. And it brought to mind something that Dr. Zennel actually said to one of our visiting learners here, I think it was about a year ago, and it stuck with me quite a bit, which is that Grand Rounds is supposed to be this coming together of great minds in our field, and we sit down to discuss exciting new topics usually to the goal of walking away really, really stimulated, really going, wow, that really has changed the way I feel about a topic. And so when that sentiment came to mind as I was trying to pick a topic for this, it was like, man, the bar is now really high. I shouldn't have let my mind go there. But then I was coming over some recent articles in Pediatrics, and I came across a series of articles that are the topic of my discussion today. A program that's been taken on by the American Academy of Pediatrics, which at its core is meant to try to encourage future funding for pediatric research, but is highlighting many of the great achievements we've made in the past 40 years, but also predicting some of the great achievements that we're going to see moving forward. And in reading these two articles, it occurred to me that I am part of a present-day generation that really didn't experience any of these great advancements, that the medicine I practice today is the product of the work of people that came before me. And that hit me because I realized there were a lot of things that are different today than that of the generations that came before us, and we're benefiting from that. But also, I realized what's going to happen in my practice lifetime that's going to affect the generations moving forward. So someday, I'll be that attending that is speaking with my learners and saying, back when I was a resident, we didn't have, and I started going, what is that going to be? And that really was the inspiration for this talk. And so kind of the disclosures that we typically give, I have nothing to disclose, but just that the pictures that you're going to see here, the graphs you're going to see here in this conversation today are largely from the articles that I've referenced, and I'll list here for you. And anything else that's not from the article was on like Pinterest or something, but I don't own them. And this is one of them, freely available online. So the objectives for today, two very cookie cutter obvious examples. And so our goal with the first article, the great achievements in the past 40 years, is to recognize the contributions made to pediatric medicine through research and clinical practice over the past 40 years. And then with the second half of the talk today, which is going to be the things that we're predicting moving forward, we're looking to recognize the potential impact of future research in pediatrics, which will continue to shape our practice. And I am going to take a moment between those two elements of the talk to canvass you all as the audience to see what you think the next big topic in pediatrics will be, what you think, whether it be in your particular discipline within pediatrics or in pediatrics in general, what do you think the big hubbub is going to be? So prepare yourselves, because I'll try to get a handful of ideas from you all, because I can stand up here and give you my thoughts all day. But what I want to know is what you think. And probably a good point to ask, I know Dr. Zenel is aware of this series of journal articles, but is anybody else familiar with this past 40 years advancements? No? That's perfect. Okay, great. So the last two objectives that really, again, kind of dial back to that feeling I had as I was trying to come up with what I wanted to share with you for my grand rounds, was to think about what you think is going to be the future of pediatrics, especially for the top left corner up here, my fellow residents who are starting their careers, but then also what your contribution might be to those great advancements. And so this is the 7 great achievements. This is something freely available online. It's a large program that is on the American Academy website. 7 great advancements in pediatric research over the past 40 years, authored by Dr. Cheng and colleagues. And so this initiative really was an attempt to educate our congressmen to recognize the value of funding in pediatric research, see what we've accomplished over the past 40 years as a result of that, and then try to encourage the funding moving forward, which unfortunately has declined and stagnated significantly over the course of the past decade. And so they start this article with a quote that I appreciated, and again, really hit me in the feels about the reality that I am practicing medicine that is the product of the generations before me. And so I am going to read it to you here. We live in extraordinary times thanks to medical and scientific advances that even a generation ago would have sounded like science fiction. An American born today has a projected average lifespan 20 full years longer than one born in 1925. And it made me think, that's true. My attendings are telling me about the mortality they experience, the morbidity they experience with their patients, and how much that has changed today. So without further ado, we'll get started with great advancement number 1. And so I was told by Dr. Bula that if one of the advancements wasn't antibiotics or vaccines, that he'd be severely disappointed. And so I'm glad I was able to deliver that today. The first great advancement that they list is the mortality and morbidity impact we've been able to make with vaccination. And the 2 examples they give are rotavirus, which admittedly has a much larger worldwide impact, and the Hib vaccine. So to start with Rota, Still, diarrheal illness, particularly secondary to rotavirus, is still one of the leading causes of mortality in children under the age of 5 worldwide. There are national and international programs to try to address this problem, but many parts of the world still do not have access to clean water and sanitation. So in 2008, the article talks about how 500,000 children died under the age of 5 secondary to diarrheal illness, such as rotavirus. And so research into vaccination started in the 1970s, and vaccines here in the US became available in 2006. The graph here to the right side, I'm hoping you can see okay, but it's really the general picture I want to point out to you, which is right here where this seasonal peak in testing and positive rotavirus testing really changes once we start vaccinating. And so you can see kind of very visually that a huge impact was made. And so we're talking about diarrheal illness worldwide and trying to get a sense for what that impact is here in the United States. And again, this is not something I experienced. Admittedly, I was still in high school when we were dealing with this problem. And so to look at the numbers prior to vaccination, something on the order of 30 to 60 children each year would die secondary to seasonal influenza. And so at about that time, we're talking about 2 million children and about 3 million today. And so maybe the real impact has to do with hospitalizations. And so they're predicting that we save probably 70,000 hospitalizations now with vaccination due to rotavirus, the availability of rotavirus and routine vaccination, and that using this routine vaccination, we're able to prevent illness by about 86% and reduce mortality by about 95%. So that's a really big impact. But globally, with public and private organizations such as the Gavi Vaccine Alliance, we're able to prevent a predicted 2.5 million deaths across 72 nations who participate in this vaccine alliance from 2011 until 2030. So that's a really big impact on childhood mortality. HIB for me was an example that I go, oh yeah, I've heard that story from a lot of attendings. One of the things we learn in residency is sick, not sick. And I understand now a little bit better how much of an impact invasive Haemophilus disease was prior to vaccination. The reality that 20,000 children a year would experience invasive HIB disease. So we're talking, pneumonias, meningitis, bacteremia, soft tissue infection, and that the mortality was huge. We're talking 1,200 deaths a year, on average. And so looking at influenza season right now, we're seeing, 84 deaths, I believe, was the total pediatric count last year, which this is a pretty devastating influenza year for us. And to consider that 1,200 a year would fall, and that's just mortality, not morbidity. So kind of hit me a little bit. I go, yeah, I can see that the stories that they told me, the numbers really do kind of send a take-home message. 12,000 cases of meningitis a year secondary to HIB. I just, I can't fathom what that must have been like. And fortunately, I live in an era post-HIB vaccination where our sick, not sick looks a little bit different. So that first vaccine was available around the 1990-1991 time. And what's important about this is that the real big mortality and morbidity associated with HIB is in that under 1 group. And so there were earlier versions of the vaccine that were started at 18 months of age. And you can see there is a little bit of a dip. We do have improvements in invasive disease with the first 2 versions of the vaccine. But with the third box here, we're now vaccinating at age 2 months, getting that response early in life so that we can prevent mortality. And oh my goodness, the decline in this graph it really makes you understand how much things have changed. Great advancement number 2. Dr. Blake called this one from the audience this morning at the onset of my talk, but the SITS campaign, something so simple, so easy as saying, gosh, putting our kids on their back to sleep can have such a huge impact. So in 1992, there was kind of a culmination of research and ideas internationally from the UK to the United States, Ireland, Australia, and these studies, these case control studies, demonstrated that sleeping on your back is predictive, that by prone positioning, you're going to increase your risk of sudden infant death by 2 times. And so in 1993, we had a peak in our sudden infant death rates with 4,700 infants who were lost to SIDS. In 1994, we started the Back to Sleep campaign, and we watched an incredible decline in the number of deaths, more than 50% reduction by doing something as simple as educating our families to put their kid on their back when they go to sleep. So you can see 2063 and 2010, and this is a nice graph that's provided by the article that really shows you that big change where we were able to take something on the order of 13% of babes who were put in supine positioning for sleep prior to this initiative to over or nearly 75% by 2006 and still more today. We do know there are gaps here in research still. We know that certain communities, African American and Native American communities, there's still a large disparity in the rates of SIDS. We do know that there's a lot of other factors involved in SIDS today, and probably more research does need to be done to recognize the effects of breastfeeding, pacifier use, and so forth. But a real simple thing that's made a huge impact on mortality. Great advancement number 3. So acute lymphoblastic leukemia, one of the most common pediatric, or the most common pediatric malignancy, has had an incredible shift in the rates of mortality over the course of the past 40 years. So prior to 1950, universally fatal disease, with incredible advancements, we're now reaching near 90% survival at 5 years of age due to the things we're able to accomplish, which we now recognize based on highly disciplined controlled trials in children. So today, as we learn it, the residents that we have today, we go to our hemonc rotation and we learn about this as if it's always been here, but the reality is that it was not. And so we look at combination therapy, intrathecal chemotherapy, now largely replacing cranial radiation, or exclusively, intensification phases and risk stratification based on presentation with CNS disease, no CNS disease, age, and so forth. And so now we have this incredible success story where we've taken a devastating, very common malignancy and made it something that is very largely survivable by children. There's been a lot of shifts in treatment paradigms too, such that very small percentage of ALL, Philadelphia chromosome positive, once upon a time had very poor outcomes, but we were able to recognize through, again, controlled trials that introducing a tyrosine kinase inhibitor to chemotherapy regimens would really improve our survival outcomes. And so that was a huge success in hemonc. And now we're starting to recognize with some preclinical trials that there's this other element of B-cell lineage ALL, about 10 to 15%, that is Philadelphia chromosome-like, where we have the chromosome mutation, but the BCR-ABL fusion protein is not there, which traditionally has had poor outcomes. If we treat it like Philadelphia positive and introduce those tyrosine kinase inhibitor into the chemotherapy regimens, we're getting similarly improved outcomes in survival. And so this is a big deal. We're avoiding some of the high-risk maneuvers that we're needing to provide to children, things like bone marrow transplants. We're not going to be needing that as often now that we're recognizing how to treat these. Tailored medicine, it's a huge deal. And this last topic I won't get into too much because kind of a teaser for the next part. It will be part of the discussion for the future. But immunotherapeutics is a huge niche field now in hemonc. And so we're talking about using advancements like harnessing the immune system to fight the cancer. So teach our immune system what the cancer looks like so that the body can fight it off on its own. Particularly exciting, currently undergoing clinical trials today on the use of CAR therapy, so chimeric T-cell antigen receptor therapy, where we are genetically modifying our own immune system to say, hey, this is the cancer, treat it. And so for kids with relapsed ALL, which has pretty dismal prognosis, we're now seeing huge success rates in using those children, introducing immunotherapeutics. I actually just heard this on NPR yesterday. They're doing this in China with like tons of cancer. But anyway, so this is a huge improvement. And so Harvard is one of the greatest advancements in the past 40 years, secondary to some of our research efforts. So this is just kind of a sexy graph. This talks about some of the cancers that we see in pediatrics, the two most common being our leukemias, lymphomas, our CNS disease. And you can see in that top part there, the black line, this is increasing rates of common leukemia. But over that same time span, looking at the rates of mortality, I mean, look at that black line. That is a huge decrease in the rates of mortality secondary to leukemia. So a huge impact that we've made there in a very common cancer. Big advancement number 4. So saving premature babies with surfactant therapy. And again, I live in the NICU era of today, but for many of our neonatologists who have lived and practiced for greater than 25 years, they talk about the era before surfactant and the era after surfactant. And so I did a little bit of history and I learned a little bit about this guy, who is Dr. Clement. He, was an Army physician who originally trained at Cornell, and he went on to do some research at a Maryland lab, I think an Army chemical lab, and thought he was going to get to do some cool biology with this mentor of his, but came to find out that his assignment was to become a physiologist. It was a big time for the concerns about nerve gas and the Cold War era, and he said, you're going to be a physiologist. We need you to figure out how to protect our troops from nerve gas. And so I think largely disappointed initially, he dumped himself into this research. And because of those efforts, ignoring some discrepancies that were disregarded by other researchers in the field, was able to recognize that there was just something different about the physiology of the lung, something allowing us to alter that surface tension so that we can expand and relax the lungs and lung tissue the way that we do. And so he called this anti-atelectasis factor. Didn't know exactly what it was, but knew it existed, and went on to discover the reality that we know today, which is that surfactant is supremely important to normal lung function. And so his landmark paper came out in Experimental Biology and Medicine in 1957. He went on to be involved in neonatal care, did the animal studies, was involved in the animal studies along with some folks overseas to discover animal surfactant and the use for our NICU babes, and then was also involved in artificial surfactants as well. And so, again, large-scale, randomized, blind, placebo-controlled studies recognized that this was a huge benefit to our children, and it is one of the hallmarks, the foundation almost, if you will, of how we treat prematurity today. And looking worldwide, prematurity is a huge cause of mortality worldwide, outside of the U.S. and within the U.S. And so still the leading cause of neonatal death is this premature and immature lungs, and still 1 in 9 infants today is born with premature lungs. And so a huge impact thanks to this guy, maybe we call him the granddaddy of neonatology. Great advancement next to be discussed is the prevention of HIV transmission from mother to baby. And so again, I'm a babe of 87. I was not alive and in practicing medicine during this era, but with the peak of HIV in the 1980s, we were also seeing huge rates of transmission from mom to babe. And so looks like the peak year, I learned in this reading that I did, was in 1991. We had 1,650 babes that year that had contracted HIV from mom in the delivery process. And so, some articles talk 20 to 30% transmission, but some up to 40% in the studies that were done at that time. And so this became a huge focus within pediatrics to say, we've got to stop this. We have to keep these babes from starting their lives the way that they are. And so with the recognition of a very important drug, zidovudine, which we now know, very well today, they were able to treat both mom and babe and have up to 2/3 reduction in the transmission rates of HIV. It's just an astronomically impressive accomplishment. And so it was in 1995 that the American Academy of Pediatrics and the CDC said, we need to start screening moms universally. This is like a non-negotiable thing so that we can be treating these babes and making an impact, a lifelong impact on their children. And so today we have what we call universal precautions. So we're universally screening moms and babies. We are treating moms and babies when we find positive titers. We are using C-sections where appropriate for those at high risk for transmission. We are deterring breastfeeding in situations like in the U.S. where we have reasonable options. And we've been able to reduce transmission rates of HIV to well below what we've seen in the past. In 2013, there were 93 cases, a 94% reduction in the amount of maternal to fetal transmission since 1991. Again, it's hard almost to fathom that. I was fortunate enough or unfortunate enough to have a babe that, in my experience in residency, we discovered as an infant was HIV positive, but to realize that is probably, I'm very fortunate maybe to have had that learning experience as a resident because we're just not seeing it as much as we used to. And so this graph here, again, a lot of really nice graphs that came out of these articles looking at how much the transmission rates had declined with the advent of these new precautionary screenings. And so another fabulous advancement. Number 6, great advancement, is actually 2-part. It's extending lifespan and quality of life for those with chronic disease. And the 2 large chronic diseases that they highlight are cystic fibrosis and sickle cell disease. And so this is Danny Bessette, kind of a poster child or now poster man of cystic fibrosis, well known to the community. This is him pictured in a Nature article in 2009, and he's holding a magazine with him featured on the cover from 1990, where he was age 4. And so that 1990 article in Science magazine talked about how we have a huge gap in our knowledge and awareness of how to treat kids with cystic fibrosis. At that time, there was 1 gene recognized as being contributory to the disease. Today, we have over 130 genes recognized as being pathologic in the multi-organ system disease known as cystic fibrosis. And so Danny today is 32, going on 33. He benefits from all of the current therapies that we have in cystic fibrosis management today. He's status post-lung transplant, married, I believe, and celebrated a lovely Christmas per his blog page. And so, yeah, I went there. And so, yeah, the things that we do today are hugely different from the way that they started this. And so now we have expanded newborn screening. We can detect this from day one in young children, and we recognize that there are gene mutations outside of newborn screening in certain demographics, such as here in South Dakota, where many of our Hutterite populations have mutations not detected on our newborn screen, but we recognize that, we look for it, and we test and treat. We have medications now to not only treat the lung disease, but to treat the other organ manifestations, the dietary issues. We have inhalation therapies and inhaled regimens that help keep these kids with cleaner lungs that are less frequently infected. We use nutritional supplementation. We get them involved in multidisciplinary care. If you've seen one of these kids go through our specialty clinic, they have like 3-4 visits. They meet with our pulmonologist. They meet with our nutritionist. We try to approach this from all angles. And there are huge research networks involved with cystic fibrosis to help us continue these advancements, continue the quality of life for these kids, going from what was once predicted to be less than 25 years of lifespan to much greater than 40, 50 years of lifespan today. So looking at still 250 or 2,500 kids born each year, with over 20,000 kids in the nation today, and now adults in the nation today with cystic fibrosis. As a parent of a child who's a gene carrier for cystic fibrosis, I didn't realize how much has changed today, and how it would have been devastating news for me, but to realize how much more we can do today than we would have back then when I was born even is huge. So pretty impressive stuff. This is, again, really nice graphics this article provided to me. Looking over how lifespan has really increased with the advancements that we've made today. And so you can see with each of these lines, we have new therapies that came about, kind of some hallmarks in the course of how we understand and treat cystic fibrosis. To see, I love the enthusiasm in this graph. What's next? What are we going to see coming next that's going to take this lifespan to just like everybody else? And that's the kind of stuff I expect to see in my practice lifetime. Sickle cell disease is another great example. The blocks here on the left really highlight the various elements that we use to try to treat kids. But this was almost a little bit of a sad story to me, to realize that looking back, we had understood the pathology and the genetics involved with cystic fibrosis back in the 40s and 50s, but our approach to this really kind of stumbled. It wasn't until the 1970s that we finally got universal screening on board. And so this was kind of a neat picture I found of that first legislation to say, no, we need to be screening these kids, just like we do with cystic fibrosis and many other conditions, to treat from the very beginning. And so that was the first step. But now there's a lot more that we can do. We can watch these kids, monitor their rates of velocity in the brain. We're preventing the risk for a stroke. We're using regular transfusions, elements like hydroxyurea treatment paradigms, shifting even today in how we manage these kids and extend their lifetime. So this is a huge advancement. Kids now, once predicted in 40 years ago to live maybe to the age of 14, similar to cystic fibrosis, now living long beyond that into adulthood. Hugely important advancement. Another graph similar to the last, where you can see kind of a long, kind of not so exciting slope until more recently, but again, huge improvements made in the last 40 years, which should be celebrated and continued. So number 7, this is the number 7 big advancement that I was kind of surprised. This is not what I was expecting, but no less impressed by the results. So by the studies that we've used today in terms of using car seats and booster seats in children, we've really made a huge impact on mortality. So today, even still, common cause of death under the age of 17 is traumatic motor vehicle accidents. And so by encouraging the use of seat belts, but not only seat belts, car seats properly used. If you've been in an elevator in the castle in the past year, you know you've got to be like yay tall before you're not allowed to use a booster seat. And we've made huge impacts on that. We're talking up to 75 and 50% mortality reduction by using car seats in our infants and toddlers. Booster seats, when compared to seatbelt use alone, reduced by 50%. And then with our teen drivers, recognizing that you probably shouldn't just hit the highway without any sort of graduated program, some monitoring and graduation of how much you should be on the road. We've reduced injury and fatal crashes in kids at the age of 16 with studies that we're seeing today. We're having a lot still, I think, to really study in this area, and this is one of the only slides that I pointed out some of the advancements to come as it pertains to driving, because, yeah, okay, we know that car seats save lives, but we got to get them to people, and there are demographics that still today struggle to be able to access and afford car seats. That's a really big problem, and so this is stepping away from bench research for a second to say public health problem, people. We need to get these families the tools that they need to keep their kids safe, rear-facing for as long as humanly possible. But those car seats are expensive, so how do we get them to families and educate them and use them properly? And then recognize that there are demographics that still have disparities, and maybe it's not related to affordability, but we kind of should figure out why. So low-income communities, teens are at particularly high risk still. Not only do we have impairment issues with substances, long known to be a problem with driving, but we have cell phones, and they're everywhere. They don't stop. They're 24/7, and teens are using them, and recognizing how we can reduce fatal and injury crashes related to impaired use. And then rural settings, I almost laughed out loud when I saw this one, because I learned something new moving to the Midwest, which is that we drive a lot sooner out here relative to my experience on the East Coast. And so recognizing that there are needs in certain parts of the country that are different, and how do we address them, but also keep our kids and the people around them safe. So this was another article, another graph. I'm glad you can see the blue line. We can't see it in the back. But over the course of the 1970s to 2010, huge improvements in mortality rates associated with probably some of the changes that we've made in the safety and recommendations for driving. So those are the big 7 from the past 40 years. We've had bench research, we've had efficacy studies, we've had large, rigorous, controlled studies to recognize how we can best implement the things that we're learning, and we figured out how, in some cases, to disseminate this stuff worldwide, bringing vaccines like rotavirus across the world. So we've had a lot of success in translational research. But now we're going to shift to the next question, which is what comes next. And before I start giving you the answer to what this group of individuals who wrote these papers thinks, and actually this is a good time to say, it wasn't 4 authors that came together to say this is what they think was the most important over the past 40 years. This was an open-ended study, that was a survey, if you will, that was provided to the board members of some of the large organizations in pediatrics that came up with not only the first list, but the next list. And so I'm really interested to hear what you all think the next 40 years is going to bring for our practice lifetime, and maybe after your practice lifetime for some of us. I know we're not going to pass around a little microphone, but I'd like to get a couple of ideas, and I will repeat it for, I think we have one listener remotely who's listening, so that you don't miss out. What do you think? It's really bright up here. I can't see anything. Sorry, guys. Yeah, so he must have a crystal ball. Yeah, so one of the great advancements coming forward, how we modify genes in single gene diseases to help prevent and in some cases eliminate pathology. That's a good one. Dr. D. So, yeah, so Dr. Z calling out the future investment in vaccines to find maybe universal vaccines for our common illnesses like influenza, RSV, and Dr. Bull not as enthusiastic about how far we've come to do realistically, but it could be you, right? Yeah, up here? Okay. Who else? Yeah, sure, Dr. Bull. Yeah. Hmm. Yeah, absolutely. So the social media, perhaps, and social movements, particularly in our youth, that are talking about gun control right now, and how maybe public policy and public involvement, community advocacy can really change things like some devastating news. Yeah, absolutely. Yeah. Not surprised. Oh, yeah. Okay. So understanding neurochemical components to mental health disease and biotechnology implants. Wow. Yeah. Mm. Sure. So more investment in immunotherapeutics, not just in cancer, but in other conditions as well. All right. Who's feeling lucky? What do you think? Sorry, I can't. Oh, yeah. Thanks. Yeah, Dr. Ziegler. Mm. So healing brain and spinal cord injury rather than just treating it. And she's okay with losing her job. Okay. Mm-hmm. Yeah. So, AI-assisted diagnostic technology. Hmm. Yeah. Hmm. Yeah. Right. So that's part. We're talking about universal healthcare and healthcare policy, and that's part of that dissemination and implementation phase of translational research. Yeah, we can have the technology, but if you can't have access to it or afford it, it's not going to be very helpful. All right. We'll see how close we get there. So the next article in the series was the next great achievements in pediatric research, also by Dr. Chang and some new colleagues. And so number one, more immunizations. It was number one for our first 40 years, our last 40 years, and number one hopefully for the next. They talk about new and emerging diseases like Ebola and Zika, not only discovering a way to to make these vaccines, but to provide them acutely in the setting of outbreaks. And then also considering the fact that there's still incredible mortality worldwide with well-known diseases like TB and malaria, and what can we do to prevent it rather than just treat it. Cancer vaccination, the maybe more commonly understood approach there might be something like HPV vaccination, but kind of like a little plug for some of the immunotherapeutics is the reality that vaccines may also be part of what we use to not only prevent, but treat certain cancers. And the big one, I agree, I think is influenza vaccination and how can we build a better mousetrap, safer, more efficacious, more universally used to kind of help prevent, this is a great year. In light of what's going on this year, we need a better mousetrap in terms of preventing influenza and mortality. So, good call, Dr. C. Next one, cancer immunotherapy, and I agree, immunotherapy in general is going to be a hugely budding field in all medicine, but in pediatrics as well. But the big one, and I think this is in light of some of the clinical trials currently underway with relapsed ALL and the CAR therapy. And so the three kind of elements that they talk about are monoclonal antibody use, which we already know in medicine and we see in other disciplines, but also dendritic cell therapy, so vaccines wherein we use our own immune system, recognizing the cancer and bringing it back to the body. But then this new element, and that's in the bottom here, where we can take our own T cells. This is kind of a little graphic of that. We're talking about just yesterday, like I said, NPR, CRISPR technology to genetically modify our own immune system to appropriately treat a devastating illness. And so there's likely, for these authors, to be a lot of investment in that. And like I said, clinical trial underway in the case of the CAR therapy. Genomics over here with our single gene mutations, that was a big one. So recognizing that our neonatal panels that we use, which differ by state but are widely used, universally used, can detect a vast number of illnesses, and so we can start those treatments early on. But as we continue to understand genetics, genomics, epigenetics, we can detect still more diseases to appropriately start treatment from day one. Recognizing illnesses like hemophilia, sickle cell, and others where single genes are the entire disease. And so if we can learn to modify that mutation, we can eliminate the disease. And so that was highlighted as being a big one. Something was new to me and I find really exciting too is gene modification. So okay, even in a situation where it's not just one gene, or even where it is just one gene, there may be other genes that address other elements of the disease. And an example of this would be sickle cell disease, where aside from the gene mutation that causes the mutated golden gene, there are also genes we now recognize that downregulate the production of fetal hemoglobin. And so let's say I turn that gene off. Maybe I can't cure the disease, but if I turn that gene off, I can upregulate the production of fetal hemoglobin, which is what we do with the therapies we use already with medications. And so maybe we can improve the quality of the illness by doing some of the gene modification unrelated to the primary gene. And then genomic monitoring. This was a big topic in this paper, talking about the reality that epigenetics is much more than we've ever understood. And so maybe a little bit to my dismay, because I found that to be a very challenging subject in medical school, but recognizing that if we can understand these tiny mutations that are maybe not going to cause disease today, but are going to put you at higher risk for disease as an adult, we can screen kids, we can detect high-risk children, and recognize those epigenetic changes, those genes that are getting switched on to prevent disease from becoming a problem. We can be preventive as opposed to reactive. Big data. And so as much as I strongly dislike how much time I spend at a computer with electronic medical records, it is a hugely vast gold mine of information and data. And if we can take that information that we have to kind of mine it, harness it, use it to our advantage, we can start to recognize trends. I know that there are some folks here at our children's hospital that are already interested in recognizing some of the things that might flag in an EMR. And in this case, they're talking about adverse childhood outcomes and how this might put kids at higher risk for illnesses later on as adults, such as cardiovascular disease, diabetes, obesity. And so if we can recognize these things, finally a pop-up that's useful that says, hey, based on some things that I'm seeing, this kid may be high risk for some epigenetic changes that's going to put him in a high-risk category as an adult. We should be screening for hyperlipidemia, even though this kid didn't flag based on his family history. That could be a really big deal. And rather than the nature versus nurture that I learned once upon a time, maybe nature is nurture, that they're one and the same and interrelated. They highlight the reality that, yes, we see trends. For example, kids that are born small for gestational age are going to be higher risk for cardiovascular disease in an adult. And we know that certain heavy metal exposures might cause some small for gestational age tendencies. And so maybe it's just not a causal thing, but a related thing. Now we're realizing that there are epigenetic changes that happen, that it's more than just coincidence. And so if we can understand that a little bit better, we can treat and detect this a little bit better too. We understand well, and this touches a little bit on your point, Dr. Zenel, about neurophysiology and the reality that certain exposures, both to moms who are pregnant with infants, but also after in those first vital years of growth and development, that certain exposures can, again, not just change the biology and the physiology, but the genetics as well. And that is something we're going to, I think, come to understand much better. And a topic that is going to become more important in a few moments toward the end of the talk here, maternal stress response, adverse childhood outcomes. This was a huge, huge, huge topic long ago. And I don't know that we've done a lot about it. You know, we know that kids who are exposed to terrible experiences go on to be higher risk for a lot of things. Well, what are we doing about it? We have a really hard time with that. And so in this case, they're talking about moms who are pregnant, who are exposed to adverse outcomes like abuse, malnutrition, and are they themselves having a history of ACEs, are at higher risk for having children with other illnesses as well. Just understanding that better, they think, is going to be a large part of the future. To err is human, and so this kind of calls back to the, I think, 1999 release that discussed the reality that medical errors is a huge cause of mortality. And those numbers were recrunched, if you will, in 2013, and we found that still the third leading cause of death in the United States, with over 250,000 deaths associated to medical errors in 2013. We're recognizing that QI is a huge part of what we're doing now. It's becoming a bigger conversation. It's becoming a larger part of our education. It's now becoming something that we're going to be required to be doing, because realistically, we can have good medicine, but if we don't practice good medicine, it's not going to be as effective. And so in 2015, we saw nearly 90,000 fewer hospital deaths from 2010 to 2014, just as a pure benefit of saying, let's only put catheters in when they're needed. Let's take them out as soon as humanly possible. Let's recognize the high-risk patients who are having hospital-acquired infections and try to prevent them, or at least recognize them early and treat them early on. And so they were estimating something on the order of $20 billion in saved healthcare costs due to recognizing, treating, and preventing hospital-acquired infections. And lastly, translational research. So we can do great things, but if we only keep it on our own doorstep, we're kind of limiting the potential. So we take that bench research and we turn it into huge implementation, bring it to the rest of the world. So there's some good examples here and some areas that are still sadly lacking. And clean water is a huge example. I don't think anybody's going to argue that that's an area where worldwide we still have a lot of effort that needs to be made. But a couple of success stories. So I talked about the Gavi Vaccine Alliance earlier today. public-private organizations coming together with large governing bodies to say, we've got good medicine, let's share it with the rest of the world. And I think eradication of guinea worm is another example where within pediatrics we were able to take the medicine and the health that we know to other parts of the world and make a big difference. And so they expect that, again, we can do good bench research, but let's bring it to the rest of the world and let's disseminate it, let's educate and bring that health to everyone. So kind of coming to the end here, we've talked about the past and we've talked about the future. I know I have my own ideas about what's coming next, and you do as well. I'm going to share one more thing with you that I think this was potentially going to be the topic I was going to discuss today, but I'm just going to kind of leave it as something for you to marinate on a little bit, and it touches on with something else you brought up, Dr. Blake, which is the concept of resilience and adverse childhood outcomes. So we can treat strep infections, we can admit kids with infections, we can treat dehydration, treat chronic disease, chronically ill children, acutely ill children. But what do we do about those children who have had terrible experiences and who are going to be at high risk for falling ill to chronic disease as they become older? And so I'm going to share a little personal story for you all to kind of give you a little bit of an idea, and it touches on this personal statement that Dr. Zennel offered. So I was born into that small community in upstate New York, a town of 4,000, beautiful community, good school, a lot of resources. I had great teachers, but unfortunately I had kind of a terrible home life. I had parents with substance abuse issues. I had parents who were physically abusive. I left home when I was 17, almost 17, lived with friends, lived with my mom for a while. She unfortunately had issues as well, in and out of jail, in and out of rehab. I've been in an intoxicated driver's car more times than I want to admit. But I was young when I knew I did not want to end up like my parents. And I was fortunate to have two teachers in school, science teachers, role models. Jamie Sesselman, they're not here so they can't hear this, but Jamie Sesselman and Mark Millars, wonderful people who were kind of surrogate parents for me. So they said, you want to get out of this? Get out of this. You can. Work hard in school. Don't be like your parents. You can be successful. I was, I think, 17 before a doctor asked me if I felt safe at home. So that's a big deal. And so for me, I look back on that experience, and I'm actually kind of a little surprised to be a little verklempt right now, because I don't really resonate with that story anymore. I've had wonderful success in my life, a family that's now much healthier, a brother and sister who I was able to help get out of that environment later, and went on to have a wonderful story for themselves, a scientist and an engineer, and myself a pediatrician. And so looking back on that experience, I realized I was able to get out of that, and I can help children get out of that too. But how? And that's the part where I don't think we have a good answer. And so in light of last week, and this is kind of a warning for anybody that might have any trigger issues, today is different. I mean, my experience was terrible, but I didn't have the era that we have today with social media where kids are actively tweeting and Facebooking and texting people while their school is being shot up. That's a lifelong trauma. And every child in America today who has access to the internet is living this experience. If I were a teenager today, I'd wonder, am I going to go to school tomorrow in South Dakota or Warrensburg, New York, and have somebody shoot up my school? I mean, just reading this text message to me was nauseating. Literally in the moment, texting, it blows my mind. And so I think the reality here is that adverse childhood events are no longer a story about a pediatrician who had drug-addicted parents. I mean, this is something that if you're online, you're experiencing adverse outcomes just by watching this stuff every day. And so I think, for me, my future in pediatrics is going to be, how can I do something about this? How can I make more children who are going to be able to experience stuff like this and be successful? And I don't know that there's a good answer to that today, but looking forward to my future, I'm hopeful that I'm going to be able to be a part of some sort of science, some sort of research, some sort of community involvement to help understand resilience, what helps kids get out of these situations, what helps them be successful. Because I don't think that the glass half full, most kids are just fine, is a good answer. So I was a little more touchy-feely than I thought it was going to get towards the end of this, but this has been a really great experience for me to recognize where I am today, where we've come from, how much I have to learn from people who were involved in things before me, and really start to get a sense as I start my career in a short 4 months about where I think my own career is going to be going. And for those of you, my colleagues in the back row, I encourage you to think about that. You know, we're busy and we're tired and presidency is what it is, but you're just at the beginning. And so what are you going to be a part of that's going to kind of change the future of pediatrics? Thank you. supposed to start by asking if our remote listeners have any questions. All right.
I was just going to say, one thing I think that they left out, or one of the things that was left out was fluoride in water. I think that's very important. But the other thing is really systems of care. You know, I think that the pediatric childhood cancer group was started long before any of this other multidisciplinary or multi-institutional care. And bringing large centers together and doing ongoing research was huge. I mean, and I don't think you know, we talk about systems of care and how important that is, but you know, but people don't really talk about those kind of systems.
Yeah, yeah. So the remark was that you know, global systemic collaboration is a huge part of what needs to be the future of pediatrics. Yeah.
Thanks, Francesca. I don't know if you saw this morning in the Argus, there was an article about a Sioux Falls school teacher with a brain tumor who was referred for proton beam radiation therapy and was denied by her insurance company. I don't know how many of you were here last week when Dr. Mahajan from the Mayo Clinic gave a talk on proton beam therapy, and it was very interesting. But at the end of her talk, I asked her, is there any data supporting the use of proton beam compared to conventional radiation? And she admitted that there was not. And then she made kind of an offhand comment that, well, that study will never be done, it can't be done. My problem is that in the past 15 years or so, I've seen a continual erosion of scientific discipline in clinical research. I think there's two reasons. One has been consumerism. I think I started with the HIV epidemic and the ACT UP group, who were absolute political geniuses when you look at what they accomplished. Unfortunately, they weren't clinicians, and I think they kind of opened a Pandora's box by petitioning the FDA to shortcut their clinical research. The other one is when the funding for research dried up at the NIH, and big pharma and medical device makers stepped in and basically took over research. I read an article that was presented to the IRB written by a surgeon. This article says that surgical technique cannot be subjected to randomized studies because they don't work in surgery, which is almost laughable. But good clinical research is very time consuming. It takes 2 years to accrue enough patients to the different arms. It might take 2 or 4 years for the last patient to be treated and then a year off therapy. This is glacial, and it's the only way it can be done. To start with, I would like to see funding returned to the NIH and taken out of the hands of people who profit from it, and the grants will then be awarded to researchers who have no vested interest in the research. I don't know how likely that is to happen.
I think we need people to go into policy. We need people who have that interest within medicine, not outside of medicine.
And unfortunately, whoever is putting policies has nothing to do with healthcare. If anything, they're benefiting from everything that's happening right now. So if to start with, if you want to go to getting the funding instead of just us sitting here and talking about it, actually going outside and talking about it. And but we keep saying we don't have the time, we care about our families or our patients, and we don't have time for it. But somebody has to step up. And when that's going to happen and who's going to start it.
All right, so I'm just going to echo a couple things that Alaa mentioned. You know, part of the issue is we don't have a healthcare system in this country. We have fragmented, primarily for-profit institutions whose interests are, let's just say, orthogonal to what the patient might want or what we might want. And Alaa mentioned the idea of, you know, if we had universal coverage, at some point that then becomes a situation where that eventual system can actually say, well, look, if we actually invest in these clinical trials and figure out what works well, what's cost effective, that actually has payback for that system. That right now, why would anybody invest in that? Because it's going to save my competitor money when you change the insurance in 2 years.
I was just going to say, I think we've seen a trend in private foundations funding research. I think the Bill and Melinda Gates Foundation is a prime example, but other foundations, even Sanford Foundation is now, I think in the past we've really relied a lot on government funding, and I think that the politics, the way they are, we can't afford to rely as much on it. But there are billions of dollars out there in private foundations that are looking for something good to do.
Behind you.
That was good, Don.
Thanks, Bob.
So just touching kind of a point on your resilience talk, and there's a quote, back in the day, it takes a village to raise a child, and I think, you look around today, what is our village? Is there a village? You look at single parenting, it's quadrupled in the past decade. It's kind of, the home life is kind of us against the world, and if you're lucky, you have two parents to raise a child or a family. And so I think what we might see is kind of not just pediatricians, approaching on behavioral health and how do I improve the resilience in children, but how do us as pediatricians, physicians, branch off to work with the education field in schools, because you think about kids spend more time at school than do anywhere else, and how do we partner with schools to kind of engage in children and give them a proper idea of what it is like to have a healthy adult role model and whatnot. So I think that's going to be an interesting thing to just kind of watch over the next couple decades as we see the rise of behavioral health issues, and not just mental health, but really behavioral health. Between the ages of 10 and 19, suicide is the second most common cause of death in children. And so, I mean, you can't really ignore that. It's actually more common than cancer or heart disease in children, if you think about it, which is kind of sad.
Mm-hmm. Yeah. Another sad reality in the fact that public school is funded how, right? So we're kind of, that's an important outlook as well.
Yeah, great talk, and Richard, great comment. And I like that saying of, it takes a village to raise a child. And you brought up the things about school, and my wife is a first grade teacher, and I have to tell you that the problem is also at school. Mm-hmm. I mean, now to fix this problem of the massacre, they're probably thinking that she must carry a gun to school. And, I don't think they have drills for a shooter. So expose a 6-year-old, a 5-year-old, a 4-year-old to the reality of, someone can come these doors and start shooting. I mean, that's just the normalization of the absurd. Mm-hmm. And we must break the absurd. And teachers have their hand ties against many things. They cannot speak up for many of these things. It's going to be practically to the point of, well, you don't want to carry a gun, then so be it. I mean, resign or go do something else. And that's really unfortunate. What I wanted to say before Richard's comment, which I think you're right, was we need to focus on practicing safe medicine. And I take your comment of practicing good medicine. I think when we talk about the term of good medicine, we're talking about evaluations and patient satisfaction and press Ganey comments and all of that. And that's where the problem comes. If we think of practicing safe medicine, then we are thinking about all of these things. What would be safe for the children? Are you safe at home? That question that we never ask. Are you eating? Are you having breakfast? Do you have a dog at home? Do you have a raccoon? Do you have a snake at home? Yeah. All of these questions, I think, comes down to universal health care, to access to prevention, and to access and to policy making. And we all agree that's we need to start doing and working on. Vaccines are great only if we administer them.
Right.
If we don't get them, they don't work. And what right now Jenny McCarthy is more important than what she says on TV, is more important than what we say or all the evidence that we present. So how do you change that policy?
Yeah.
One last thing. And I think what's happening in the U.S. is that we have our focus on treatment. We don't have our focus on prevention. And that's everything. Speaking of the drills that they do, they don't, we're not working on preventing what's happening, going back to gun control, but we go focus on when it happens, what are we going to do about it? Like, for example, the talk yesterday or the day before we had about what's going to happen here. It's great. It's good to know what to do, but we are not focusing on how to prevent it. And as long as we keep talking about, okay, if it happens, what we're going to do, we are not talking about how are we going to stop these things. Starting from medicine, shooting, anything, all these things, we focus on treatment after it happens. We do not prevent it from happening to start with.
Well, thank you, Francesca. You put the grand in grand rounds. Thank you.